كلنا نقدر نستفيد من كل حاجة إن شاء الله. أنا هتكلم على الجينيتكس of posterior fossa anomalies. أنا كان يعني I was one of the I'm one of the European network of brain malformation، والحقيقة يعني كان ليها يعني I was honored to be there. The coast action is consists of all Europe, and they have another partner country outside of Europe, like USA, Canada, and Australia, and Egypt was one of the neighbor country that participate in this huge event on brain malformation. هنتكلم على first على development of the cerebellum. After neural tube formation, the rostral and its rostral part اللي بتتكون بعد كده البرين بتديفايد into 3 primary vesicles اللي بعد كده بتطلع 3 اللي هو 5 secondary vesicles. ال 3 primary vesicles اللي هما الفور برين اللي بيعمل اللي هو بروزنكيفالون، والميد برين اللي هو ميزنكيفالون، والهايد برين اللي هو رومبنكيفالون. الرومبنكيفالون its rostral part بيدي حاجه اسمها ميتنكيفالون. ميتنكيفالون اللي بيدي السيربيلم والبونز، والكودر بارت بيدي المايلنكيفالون الميدالا اوبلينكاتا. ده تقسيمه الهايند برين تختلف طبعا عن الميد برين اللي هو الميزنكيفالون، ده انتيتي لوحده. The cerebellum is composed of midline vermis والتو هيمسفيرز زي ما احنا شايفين هنا. ده المقاسات بتاعتهم، ده اللي هو الميد برين، وبعدين البونز، وبعدين الميدالا، والسيربيلم، والكوربس كالوزم. Clinical radiological approach of mid-hind brain anomalies, it cannot based solely on clinical presentation, although there is some presentation that some clinical feature that can lead to the diagnosis, like the hypotonia, the nystagmus, the abnormal eye movement, and especially the eye movement, especially in Joubert syndrome, the oculomotor apraxia, and on horizontal case quality and progressive scoliosis. This is one of the clue for diagnosis of hind brain anomalies. The classification is based on neuroimaging finding, and there are several classifications regarding the hind brain anomalies that predominantly involve the cerebellum, predominantly involve the cerebellum and brainstem, predominantly involve the brainstem, and predominantly involve the midbrain. This is of the whole posterior fossa. There are 5 categories that each one based on the neuroimaging criteria that we can find. Predominantly involved the cerebellum. The most common is Dandy-Walker malformation, which is a form of incystic dilatation of fourth ventricle, elevation of the torcular. It is most prevalently, it is maybe isolated or in association with other disorder like corpus callosum, cephalocele, like we see in the previous lecture with heterotopia. It is with many genetic malformation. And it's also with many genes identified, but still many genes not yet identified. Dr. Abdeslam and me published a familiar Dandy-Walker malformation in brain and development in 2006 with severe affection of cerebellum and severe hypoplastic vermis. Later on, we published about Dandy-Walker malformation with genital anomalies that they identified the gene recently in 2023 to be CAPN15 gene. Cerebellar hypoplasia, it is a heterogeneous group of disorder. It is either involving the entire hemisphere or the vermis only, or both hemisphere and vermis. The criteria clinical picture is hypotonia, structural ataxia, ocular movement disorder, intentional tremors, microcephaly, seizures, and intellectual disability. Speech and language disorder are common. Dysarthria ranging from impairment of total impairment of language to dysarthria. Behavior abnormalities is very common, is about 20% of cases as autistic behavior with cerebellar hypoplasia. Actually, this is from the paper, because I did meta patient like this. It is PT F1A gene total agenesis of the cerebellum associated with diabetes mellitus due to agenesis of pancreas. This is total agenesis of cerebellum with the gene is incriminated also in pancreatic agenesis only. Another syndrome that we published is microcephaly with cerebellar affection, as we can see here, cerebellar affection, and they have severe bradycardia. This family, we tried to find, we found the gene, but up till now we have no any other similar cases with severe bradycardia and conduction affection like this case. Sometimes glycosylation disorder associated with cerebral hypoplasia, as we see here, due to PMM2 gene. The rhombic cephalosynapses is fusion between both hemispheres. We can see here that there is no vermis here. There is fusion, and we can see the folia is as if continuing to each other. The patient usually presented with delayed and abnormal eye movement and squint. This is the rhombic cephalosynapses. Sometimes is associated with agenesis of corpus callosum. The cerebellar dysplasia means that cerebellar is present but is dysplastic. One of the most common syndrome that I see it with cerebellar dysplasia is Poretical-Chowser syndrome. They have very thin molar tooth, as we can see the Lamont gene, very thin molar tooth, but there is cyst inside the cerebellum. This is very characteristic to Poretical-Chowser syndrome. They have oculomotor apraxia, mild delay, but the most characteristic thing is that the cyst is present inside the cerebellum with a very thin molar tooth sign. Another child with the very thin molar tooth sign, and we can see the cyst within the cerebellum. Heterotopia on the cerebellum that I showed once, which is very, very rare, and we can see here the heterotopia is present within the cerebellum. And strangely that the child is presented with epilepsy, although the cerebellum was totally normal. And we didn't find the gene of it. Predominantly involving the cerebellum with neuron migration, lissencephaly cerebellar hypoplasia. This is a very big group with the microtubulosis and renin pathway that due to renin gene and VLDLR. And recently CDK5 was identified to be associated with lissencephaly with cerebellar hypoplasia. We can see this is renin gene. Most of these cases we are doing that with target sequencing because they could be easily diagnosed by neuroimaging. We can see that lissencephaly is most prominent anterior. Lissencephaly is always, we can see that it is most affected anterior and then posterior. But here it is most affection anterior than posterior and very thin brainstem and cerebellum. This is renin gene. Another child with renin gene, we can see the characteristic that severe lissencephaly is present anterior here with severe affection of brainstem and cerebellum. The VLDLR in the pathway of renin pathway, there is like pachygyria with cerebellar affection. When we see the pachygyria is present all over the brain with cerebellar affection, we could think about VLDLR, which is another presentation known as mental retardation with or without quadrupedal locomotion. This is the tubulopsis. Tubulopsis, we targeting the gene because tuba A1A is very specific as having agenesis of corpus callosum, pachygyria, and the very prominent basal ganglia that we can see it here. Very prominent basal ganglia with agenesis or hypogenesis of corpus callosum and cerebellar affection. This is the CDK5. There is total lissencephaly with severe brainstem and cerebellar affection with arthrogryposis and specific facial dysmorphism. Malformation predominantly affected cerebellum and brainstem. The most common is the Joubert syndrome, in which there is hypotonia, ataxia, oculomotor apraxia, abnormal breathing pattern, autism, variable eye movement, kidney and liver involvement. We can see the oculomotor apraxia is present here, and the abnormal breathing that was present here, and the very prominent molar tooth sign with variable severity that we can see that classified. We have a paper in neurology that classified the Joubert syndrome into 4 subtypes based on clinical presentation. One of them, we can see here that this is the facies of Joubert syndrome. You have many cases in Egypt with Joubert syndrome. And the entry here is 43 entries, means that we have 43 genes for Joubert syndrome. So we could never do it by target sequencing. We should do whole exome sequencing or Joubert panel. This is one of the Joubert criteria, the OFG, orofacial digital type 6, in which we have preaxial polydactyly, the sublingual nodule, and the molar tooth sign with postaxial polydactyly here. The pontocerebellar hypoplasia is a group of developmental disorder characterized by impairment growth of pons and cerebellum. It is frequently followed by neurodegeneration. That's why sometimes intrauterine we couldn't identify well that there is affection of the pons and cerebellum because it's a neurodegeneration starting in early life. Imaging is very distinguishable for some of them, and we're reaching now that we have 27 seen with pontocerebellar hypoplasia. Here the 27 entries in OMIM. And we can see here, this is TSEN 54. Ghada, of course, have a lot of cases, and we're always working together on brain malformation. She has, we can see here that there is dragonfly shape that we can see here. The dragonfly shape is very characteristic to the gene, TSEN 54, and we have many families. Another gene which is very characteristic that we can diagnose it is MPD2. MPD2 is, has a unique presentation of pontocerebellar in which there is affection of the white matter, affection of the corpus callosum, and the specific figure 8 here that is present in the pons. It is a very severe form. They have a very severe form of presentation that they have epilepsy since early life, progressive. Most of them are lethal. And the characteristic is, I have a patient since 2 days that we have this very unique scan. Is just when we see the patient, it is MPD2. They are working on it because they found recently a new treatment that could be started intrauterine. Another form of pontocerebellar with TOE, with genital affection. If you have genital affection, we could think about this gene directly. The Casc gene is an X-linked dominant. It was categorized as a part of pontocerebellar, but actually it is not pontocerebellar because they have no any other anomalies. Most of pontocerebellar have other anomalies, but here there is no other anomalies except there is very small cerebellum, and some of the kids have no affection of the pons. That's why it was not categorized like this, but it is an X-linked. This boy is mosaic, have some of the cell. It's not all the cell that because it is lethal in male. So this boy is mosaic. We have part of the cell have Casc gene mutation. Pontine tegmental cap dysplasia is a known actually, we are trying to find the gene for pontine tegmental cap dysplasia. We did whole exome for all the cases we have. You have about 9 cases, and all of them were negative. We are trying now through collaborative work with England that we have a long read to try to find the gene. The gene, as we can see here, the picture as we can see here the pons. The pons, instead of looking to outside, it is looking inside the fourth ventricle here. There is posterior projection of the pons within the fourth ventricle. Look like a cap. That's why it is called pontine tegmental cap dysplasia. Pontine tegmental cap dysplasia because if there is an anomaly here in the pons, so they have many affection of cranial nerve. That's why many of them have hearing loss, facial palsy, trigeminal anesthesia that lead to, as we can see here, the white cornea, even after transplantation of the cornea. I have some kids, they return back because there is no, there is lack totally of sensation in the eye. There is no blinking. The cobblestone complex, it is either isolated cobblestone leukencephaly or associated with muscle affection as Werber muscle eye and Fukuyama. This is the isolated one. We published it in 2013 with white matter affection and severe affection of the cerebellum like this. As you can see, the listen carefully is present more posterior than anterior. We have another family identified. We did it by target sequencing with Dr. Mohammed Abdel Hamid. And we can see it's very characteristic, the white matter and the listening carefully and cerebellar affection, cephalocele. All my patients have cephalocele. This is with the POMGNT1. We can see the abnormal brain stem. The cerebellum is normal here, near normal, but the abnormal brain stem with the white matter. We can see it for congenital muscular dystrophy, and you can see here there is zotohypertrophy with the Z-shaped brain stem. The Z-shaped brain stem is very characteristic. The macroglossia is very characteristic also for the congenital muscular dystrophy. Predominantly affection of the brain stem. Congenital cranial disinnervation. Sometimes there is no obvious changes in the scan, like Mobius syndrome. Mobius syndrome, there is no changes in the scan. However, there is no movement in the face. Another gene is CFP3. We can see there is leg of thalamus, and there is total inability to move the face, like we see here. The most characteristic features of it is lag of thalamus. The gene is HOXB1. The horizontal gaze palsy with progressive scoliosis, in which the butterfly shape is present with progressive scoliosis. We can see here, this is the butter-stripe shape of the medulla. This is very characteristic for the gene. If it is associated with corpus callosum, it is DCC. If it is not associated with corpus callosum affection, it is robust 3 gene. This is very characteristic. If you can see this, they could not look to the side at all. If you ask them to look to the side, they could not look to the side. There is horizontal gaze palsy. The last thing is the diencephalic mesencephalic junction dysplasia. We describe this anomaly. We can see there is fusion here between the mesencephalon and the midbrain. We described these anomalies in many years ago, and then after that, in 2012, it was the first presentation of the clinical picture of familial mesencephalic diencephalic junction defect. And the most characteristic thing is the fusion here between the mesencephalon and the diencephalon. We found by DTI that there is field of corticospinal projection. And after that, we found the gene of PCDH12. We found it in 2018 that lead to this malformation. And we can see here there is diencephalic, mesencephalic junction defect. Some of them have brain calcification. And at the end, accurate characterization of the brain malformation help in better understanding of the disorder and allow genotype-phenotype correlation and accurate genetic counseling. Thank you very much, and thank you for all my collaborators, Professor Ghada Abdesalam, Dr. Marianne, everyone in Egypt and outside Egypt.
شكرا أستاذة دكتورة مها على كم الهائل من المعلومات اللي حضرتك اديته لنا which is excellently presented. بشكر حضرتك جدا، وبشكر تواجدي النهارده في مؤتمر النيورولوجي مع بنتي الأستاذة الدكتورة مريان ومع الجروب الأساتذة الأعصاب كلهم واللي موجودين أساتذة على المنصة. ويشرفني إن أنا أقدم دلوقتي الأستاذة الدكتورة مريان هتكلمنا على pathophysiological considerations in MCD with real life case. اتفضلي يا حضرتك.
ممكن المايك؟ مساء الخير. أنا عارفة إن أنتوا تعبانين وبعد محاضرة دسمة من دكتورة مها، عارفة إن أنتوا مش شايفين قدامكم كمية جينز اتقالت قدامنا دلوقتي رهيبة، وهو ده اللي خلاني أفكر في عنوان المحاضرة بتاعت النهاردة، إن أنا بسمع جينز كتير، تيوبولينوباثي، ليس 1، دي سي اكس، حاجات كتيرة قوي، ريلين، في ال دي ال ار. فالجينز دي بتشتغل ازاي وايه اهميتها في البرين، وازاي نفكر هل ممكن مثلا زي ما دكتوره مها طبعا دكتوره غاده بيعملوا يبصوا على الام ار اي ويقول لك ده الجين